Thank you. It's lovely to be thought of as somebody's enemy, isn't it? It's much better than being anybody's enemy. Anyway, so what I'm going to talk to you about tonight is a new idea, I think, or at least one of the academics I spoke to said, oh, that's a really good idea. If you write 12 papers, you can make a PhD out of it. I thought, yes, I think I'll go and talk about it in Edinburgh instead. So it's transferred stigma, and I'm going to explain a little bit more. Well, you'll learn about it as we go along. I started out thinking about stigma as applied to psychiatric drugs as opposed to psychiatric patients, which we all know are stigmatised, when I went to a talk by a very prominent pharmacologist who, as part of his talk, made it quite clear that one of the drugs I prescribe a lot, SSRIs, don't work. He said they're no better than placebo, they don't work. So a number of people came up to me afterwards and said, oh, is that true? You know, I've been on these, they're helping me, should I come off them? No, don't. You know, take it easy. And I actually spoke to the guy afterwards and said, you know, there's mixed evidence. There is some, you know, the evidence isn't 100%, but there's evidence. And he just said, oh, you're a psychiatrist? I've never met a psychiatrist before. And the feeling I got was, oh, you're like one of them, I'm a quackbuster, me, sort of taken from Haley. I've seen this before. This is a meme I know. No better than placebo, doesn't work, clearly the person's a quack, end of story, let's just not bother investigating this any further. Anyway, the interesting thing is I then spoke to, actually this is really good, psychiatrists, quacks. That was the worry. So actually a little bit of me thought, oh my goodness, you know, am I really a quack? A little bit thought, I think I need to look into this a bit more, because I don't think I am. I then spoke to somebody I know who's a neuropsychopharmacologist, which means he's a doctor, and that means he does drugs that are to do with the brain and the mind, and he really is very firmly of the opinion that these drugs work, when correctly prescribed on people they work for. So I felt a little bit heartened, and he pointed me towards a few papers. And I then saw the same pharmacologist happily announce on Twitter, SSRIs don't work. SSRIs, by the way, they're a modern form of antidepressants, specific serotonin reuptake inhibitors. So I tweeted him back, hang on a minute, even you said they work in severe depression. He said, oh yeah, well, I wasn't referring to that. But hang on a minute, who would have said this about any other form of drugs? Oh yeah, they work if you're really ill, but you know, not if you're only mildly ill. So let's say they don't work. It was so dismissive. At that point I thought, no, I really have to look into this a bit more, because I'm beginning to think I'm actually okay. And I want to talk a little bit about, I don't know if you can read that, I rather like that. He was unhappy to learn that I'd prescribed a placebo, but when I told him it was an extra strength placebo, he was pleased. They work. I don't know if any of you have ever tried using simple Linctus when you have a cough. Brilliant. Gets rid of mine every time, and I know it's a placebo. Anyway, just a little bit about why I don't think it's really fair to say psychiatrists are like homeopaths. First off, we have got medical training, we are doctors. Second off, we've learned a little about interpreting statistics. The stuff that, the stuff we teach students these days on how to read papers and how to analyse papers is nobody's business. It's actually considered very important. Also, the difference between being a researcher sat in a university with your clinical trials and your carefully selected patients, and being a doctor sat in a clinic with one patient in front of you. So, she's nudging my son, he's obviously being disruptive already. When you've actually got one patient in front of you, you know that you've read a trial that shows the drug has a moderate effect, statistically speaking. Yeah? Now, it's very hard to tell unless you actually go back and look at the numbers. Does that mean that this drug has a moderate effect? Or does it mean it's absolutely useless in some people and brilliant in others? And the way, it's very hard to disentangle this sort of thing. And if it's a moderate effect, there's some people who seem to do really well and others that don't do well at all. And clinically, that's my experience. Some people do really well, others don't, and some are in the middle. But there's a reasonable amount that don't respond. But when you do, you do. Little things made me think, hang on, we're not like homeopaths. Homeopaths believe in what they do. I don't actually believe in what I prescribe. I hope it's going to work. I hope I pick the right drug for the right patient. And if I haven't, I'll say, look, this is my best guess. I think this is going to help you. If it doesn't, that. We'll talk, well, they're going to come back anyway. We'll talk about it again, and we'll have another think, and we'll see if we can find what does help. I'm not saying this is a miracle cure, this is going to sort you. In fact, back in the day, I used to think that antidepressants didn't work for teenagers. I won't say how long ago it was, but it was before SSRIs came out. They just didn't work. Whenever you prescribed them for teenagers, they did not work. SSRIs came out, and we thought, well, let's try, because we've got some really unhappy, or not unhappy, depressed teenagers, and it worked. Now, my interpretation was that they hadn't taken the old ones because the side effects were so awful. But the point was, I wasn't just saying, oh yeah, these will work wonders, and I was going to say something about a different drug, I won't. By the way, it's a very small audience here. If I ramble or if something I forget isn't common knowledge, I'm really happy to be interrupted.
Sorry, can I just ask you a question quickly?
Yeah.
Was the pharmacist trying to sell something else as an alternative?
No. In fact, this wasn't his field.
Oh.
It wasn't his field. He just threw it in at the side. He's a guy I really respect.
Is his name Dave?
Pardon?
His name Dave?
Yes. I do respect him, but I think in this particular instance, I think a little knowledge can be a bad thing, and quite honestly, it doesn't matter how experienced you are in what you do. It's something I think, and I don't know how many of you consider yourself skeptics or go on skeptics things, but it's easy for everyone to be lazy. The way skeptics are lazy, and sometimes makes me cringe, because I've got a philosophy degree as well, so I tend to get a bit picky about philosophy, is they apply, oh, I've met this before, that's no correlation without whatever. I shouldn't have had that half point, should I? Correlation doesn't equal causation, or, oh, that's the no true Scotsman fallacy, and they've got it slightly wrong, but they apply it anyway. And I think that's what he's done. He's got a meme, oh, no better than placebo, quack, you're a quack. And I think it's just simple. I think it's lazy, but I think it's simple, and that's not his field, so why should he investigate it further? I just wish he wouldn't put it on Twitter. The annoying thing was, he then asked me for my evidence, and I'm not an academic, and I don't keep track of papers, so I have my evidence now. This is my evidence. I'm going to show you graphs later. So, transphobic stigma. What do I mean by it? Where am I coming from? Well, here's a group of people, psychiatric patients, right? We all know that people who have diagnoses, psychiatric illnesses, are stigmatised. The illnesses are stigmatised. It's much harder to say that you have psychiatric illness than any other kind. We all also know that doctors who treat them are stigmatised. When I became a doctor, I had a thrilled mother, my daughter the doctor. When I became a psychiatrist, she was a little miffed. And said, well, can I just still pretend you're a proper doctor? And when I became a child psychiatrist, studying child and adolescent psychiatry, that was the lowest of the low. Basically, I just tell people how to bring children up. I'm just an interfering busybody. So it's not. So everyone knows that. It's common knowledge. But what I'm going to suggest today is that actually we also apply stigma to the drugs. That was a good picture. I mean, that picture says it all. That's a tidal wave of psychiatric drugs drowning our cities. It suggests that I might be on something, I think. So, just a few things to show how stigmatised things are. Psychotic British section. This was above a picture of a very ill, very unwell Britney Spears being admitted to hospital. Really cruel, unpleasant, and just not nice. This one was about Gaza when he was admitted. I think it's an addiction problem. You wouldn't say someone was pitiful because they went in with prostate cancer. So why say pitiful when they go in with addiction depressant? It's not nice, and it's wrong. This is from the Daily Mail. I had to include the Daily Mail, didn't I, really? Basically, someone had killed someone, and the someone who'd killed them had a psychiatric illness. So, basically, we shouldn't be worrying about treating them, we should just be dealing with them. The point is, if you have a psychiatric illness, you are much, much more likely to be killed by somebody else or of your illness than you are to harm anyone. But everyone still thinks it's the other way around. Things have got better. This is one from 1996 of people. They were sort of suggesting a Sarah's law for anyone who's ever had a mental illness. Oh, that man down the road I saw, he's being depressed, want to watch him. It's just horrific. Thank God it's not that bad anymore. As for the drugs, of course the drugs are stigmatised as well. I treat hyperactive children amongst other things, and I've had parents coming in with the front page of the Daily Express saying, oh, it says that these drugs kill people. Nobody says there? Oh, monsters. Even being linked to suicide. That's a bit weird. Even if it has, you say it has. It's just not. It's not. The sin has its problems, but that's not really one of them. I know it's killed people, and sold it to someone else, and someone else has taken it. But the point is, it worked. Actually, just apropos of ADHD, did you know about a third of the prison population has ADHD? Untreated ADHD is not very pleasant. It was a policeman who told me that, done a PhD, and it was really interesting. You know, we're not just medicating people, as I'll say. Here's another one, this one really irritated me. Happy pills. Happy pills. I mean, I know everyone uses that. If you have someone who's severely depressed, I mean, this is implying that we all think we could do to be a bit happier, so we'll pop some pills. That's just not true. Of course, tablets have side effects. They all do. If you're well, you're not going to choose to take something that's going to give you side effects, but if you're ill, it's a balanced decision. I'll put up with the side effect because it's worked. It's severe pain. Yes, I'll take the codeine, even though it's going to make me feel drowsy. It's a choice, isn't it? It's a balance, and the same's true for any psychiatric drugs too. By the by, this happy pill thing, just something to think about. How many times have you heard of people killing themselves because of physical pain? And how many times have you heard of people killing themselves because of mental pain? It's not trivial. I remember seeing Norman Tebbett's wife being interviewed. Well, no, it's not seeing, I heard her on Desktop Exists. And Sue Lawley asked her, if you had a choice, you're in a wheelchair for life, and you suffered from depression for a year after the bomb, which would you forgo? Would you be in a wheelchair, or would you have suffered with depression? She said she would be in a wheelchair for life, rather than go through that year of depression again. It is serious. You know, we're not talking about happy, but I mean, how irritating. Here's another one, medicine for shyness. Should NHS give patients antidepressants to help them talk to strangers? The only people I have personally prescribed antidepressants for when they've been shy are people who are so crippled with anxiety, actually teenagers, that she could not go to college. Bright kid, she eventually left with 4 A's. She could not go. She was crippled. It's, you know, not shyness. It's belittling. I'm getting really angry on that. I'm awfully sorry about that. This is a Scientology thing. Psychiatric drugs dehumanise, disable and kill. Yeah, right. I was going to say something else about... oh, never mind. Some books on the subject. Oh, my favourite here, Talking Back to Prozac. I looked up some of these books and I was following them to the links. This guy, Talking Back to Prozac, don't take drugs, buy my special treatment. It's really expensive and it told you where to get it. I just thought that was brilliant. But there's an industry, isn't there? It's almost up there with the My Childhood Was Horrible type books. I think they're equally good as well. I would be happy to tell you more about these, but I think you'll get bored. Oh, right, graphs. So, we've established, I hope, that there is a stigma against mental illness, that people don't want to acknowledge how awful it is, and that actually the stigma transfers to the drugs that are used to treat mental illness. So, back to my am I a quack question. This first graph I'm going to show you, because it was published in the BMJ Online just 2 weeks ago, and it looks at the physical consequences of mild mental ill health. I'm not going to make you look at these graphs in detail, they're just sort of to show I'm not making it up. The important one is this. The GHQ score is the score GPs do. Anything up to 3 is perfectly normal, and then the top 3 are when you've actually got much more serious illnesses. What's really interesting is that premature deaths from all causes starts right low down. That's really mild to moderate psychological ill health. For cardiovascular diseases, same. External causes, accidents, that kind of thing. You know, cancer only at the top. Why mental illness causes more excess cancer deaths when you're very severely ill, I don't know. But again, it's just making my point, these things are serious. It looks really complicated, so I'll have to explain it quickly first. This next one is from the British Journal of Psychiatry this year. This was all terribly serendipitous, because I already told Ash I was going to want to talk about this subject. And an article is published looking at a combination of, I think it's 31 to 52, either 31 or 52, randomised controlled trials looking at psychiatric drugs against medical drugs, seeing what their efficacy is against placebo, seeing how well they work. And I loved it. It absolutely made my day. The blue ones are the psychiatric drugs, and the white ones are medical drugs. The higher you are up the hill, the more efficacious against placebo or standard treatment the drug is. I know, it's just so equivalent, isn't it? So why are we hearing everyone banging on about how psychiatric drugs are... I think, actually, because they think you should just deal with being shy. Oh, I remember what I was going to tell you. All that stuff about deal with being shy, it's just who you are. You've heard that, haven't you? Oh, people have different personalities. We shouldn't be medicating for personality. It's one of them. Another one, but what would happen if Vincent van Gogh had been treated? We wouldn't have his art. You selfish buggers. Seriously. But everyone's heard that argument, haven't they? So that's actually suggesting that these things do work. Okay, what about placebos? What was I going to say about placebos? Right. Now this is going to get a bit more difficult. All the things we've been talking about compare people who are put onto psychiatric drugs against placebo. So I'll stand away from that because I don't know. Now there is a placebo response. There's a well-known placebo response. So this next trial I'm going to show you takes people off psychiatric drugs and puts them on placebo. So there will be the placebo response will be really muted, yeah? You get people who've been on drugs for a year or 2 years, maintenance SSRIs. You take them off, either continue their treatment or you give them a placebo. See what happens. It's incredibly dramatic. Very briefly, this is people who've been... these people... Anyway, I can't remember. But this is how long people have been treatment on before. So they've either been on treatment 1 to 2 months, 4 to 5 months, or longer. These are people who've been on it. These are how long they've been stayed on it afterwards. I haven't gone over that this recently. You can tell, can't you? These are people who are kept on maintenance for a year, maintenance or placebo. These are people who are kept on maintenance for 2 years, a year or placebo. These people haven't been on it so long. These people have been on it a long time. And you can see that the sort of take-home story is that the relapse rate in placebo is 41%, active treatment is 80%. That means that treatment reduces the odds ratio of relapse by 70%. That is pretty dramatic. So these drugs work when you're taking them off against placebo. One thing some of you might be thinking, some SSRIs have withdrawal symptoms. Some, like Suroxat, has pretty unpleasant withdrawal symptoms. Fluoxetine has very few. There's another drug, it's very new, I'm not sure it's actually on the market, it's called agomelatine. It's based on melatonin rather than any other. I won't bore you with the details, right, although if anybody wants to know, I'll tell you. The thing about agomelatine is it has no withdrawal. It's established. You just take it or you don't take it, like you're taking melatonin for coming back from holiday, for jet lag. This is the graph when people are taken off agomelatine against placebo. So these are the proportion of people who have relapsed. This is time in weeks. So if you follow the red line with the agomelatine line, about 20% relapse over 24 months. If you follow the blue line, which is the placebo, we get down to only 30% still well. That's 70% have relapsed.
Can I just ask, have these studies been replicated, and are there the kind of numbers behind them? Kind of,
these are very new. This is. I've put. If you want to look them up, I've actually put all the references at the end. And I'm going to Ash have copies. You're very welcome to. It's very new. A lot of this is very new stuff. This is 2010.
So can I also ask that question? This assumes that patients have been taking an SSRI for a certain amount of time, and then they're switched to something else. How would it be ethically possible to do that without some knowledge?
They would know, right? When you're doing a clinical trial, it has to be full disclosure now. So they would have agreed to go into a trial. They would have been people who've perhaps been discussing coming off medication anyway, and they would have agreed, okay, I'll go into the trial. I don't know whether I'm going to get placebo or I don't know if I'm going to get an active drug. So that's how it would work. Just like if you were going to put people on it.
So they'd be on the active drug for a period of time and then just taken off it?
Yeah, these have been on it 1 to 2 months, 4 to 6 months, 12 months, 4 to 6 months. Yeah.
So
they've been on it, and it is considered that it is working and that they are being maintained well on it.
And then they're taken off it.
And then they're taken off.
Without their knowledge.
Well, they don't know. They know that they may be being taken off, but they don't know whether they are or not. All they know is that this might be a placebo, it might be a real drug. Which is very much the same as the other way round, when people go in for a placebo-controlled trial and they say, well, I might be getting a real drug or I might be getting a placebo. I want to say a bit more about placebo response, because this, I was blown away when I heard this. There's a placebo institute in, I'm going to leave loads of time for questions, which is what I want us to do. There's a placebo institute somewhere in North America, and looking at the placebo response, and it's people like this who come out and tell us that the placebo response works, even when you know it's a placebo. Sorry, it's for that. So they did a brilliant experiment using albuterol, which is an anti-abstinent drug. So they got people who come in, presumably not actually in really, really severe abstinent attacks, but in not very nice ones. And they were allocated to one of 4 groups. So you get somebody coming off the street into a hospital with asthma. They agree to go into a trial, and they get one of active treatment, which is the albuterol, which is very much like the blue puffing inhaler people take when they've got asthma. Or they take a placebo, or they have sham acupuncture. I don't know why that was thrown in, but it was. Or they're asked to sit on a chair and wait the same length of time. They're then given a questionnaire, and they're asked how well the various things have worked. And this is brilliant. They're all equally effective, except for sitting and waiting. So whether you have the active drug, whether you have the placebo, or whether you have sham acupuncture, they all work. Everyone says my breathing is better, I'm feeling fine. The people who sat and waited were not happy, obviously, but everyone else was. Now, you're thinking, hang on a minute, everyone knows that these drugs work for asthma, surely. Now, the advantage of physical illnesses compared to psychiatric illnesses is that there's an what do you call it, an independent test. For asthma, it's the peak flow. You get them to breathe out really quickly and see how fast they can breathe out. And if they're asthmatic, it's going to go at the end as the airways constrict, because your airways constricting. So when you did peak flow on people, that's what you got. Albuterol worked, none of the others did. So these people here in the placebo group and the sham acupuncture group felt better. They actually thought they were breathing okay, but they weren't. Yeah.
Oh, no.
Oh, sorry. I just like being asked questions. So where does this leave us in medicine where we're a little bit behind? And I think we'll find things in psychiatry, we've just not found them yet. At the moment, the research that's going on in terms of testing psychiatric drugs, there's a lot of researching going on in how to evaluate them. It's all about, do you sit down with the research and go through a questionnaire? Do you fill in self-report forms? How can we best capture the data? Well, I suspect our data capture is pretty crap, actually, if we're only asking how people feel. You get a bit circular. You can hear I'm going to get circular now, because actually when you're giving someone an antidepressant, all you can do is ask how they feel. And is that good enough? Is feeling better okay? Well, one thing we know about the placebo response is that it doesn't last in the same way as a real drug lasts. It wears off. There's only a certain amount of time that you can go, whoop, this is great. I use the placebo response when I'm prescribing. You know, if I'm going to give someone something, I'd rather they got better than I knew that it was the drug or something else. Oh, by the way, disclaimer, I've talked all about drugs here and psychiatric illnesses. Drugs are very rarely my first-line response, except for very serious illnesses. So for anyone asking me about psychological treatments, I'm just not talking about those today, but that's not because I don't think they're really, really important. So back to psychiatric drugs. Is there something going on underneath that we're not yet clever enough to have got hold of, that actually these drugs are fixing because they... If I say, because they work, I know they work, I've seen them work, I sound like you quack, don't I? But for the reasons I gave you earlier, I don't think I am a quack. And there's one other thing I'll mention. It was a drug that I saw Ben Goldacre, my junior colleague, talk about on at the Uncaged Monkeys tour. He talks about a drug called Adolescent. It's a new antidepressant, and it was released with a fanfare. It worked on a slightly different neurochemical, so therefore could be expected from first principles to be targeted at a slightly different kind of depression. We all went, wow, so this will be really good. Tried it. It never bloody worked. Sorry, it never worked. It really never worked. I gave up trying to transfer people onto antidepressants I knew worked, and hey there we went, and I lost this wonderful thing that's meant to be good for motivation. I then talked to colleagues, and they'd had exactly the same experience. They'd all stopped prescribing it, 'cause it didn't work. And Ben Goldacre put the name right across the screen saying, here's one that drug companies got wrong. We used it. He said he used it, and it didn't work. And so I think we're doing something different from the quacks, David. I think we're using our scientific training, we're using our scientific background, we're using a touch of art, because all doctors like to think that it's medicine and art. You ask the doctor who doesn't tell you that's about medicine, and they'll want you. And so I think, first of all, that these things work. Second, that there's lots of reasons that good academic researchers might get it wrong, so I'm not dissing them too much, I can understand where they're coming from. But most importantly, why are we so keen? Why are we so desperate to say they don't work? Why are we so desperate to say you should deal with this, when we know that this is what makes people kill themselves, not physical illnesses, not pain, not physical pain, we can cope with that. So why do we want to do it down so badly?
Sorry, can I just say, I think it's a bit of an unfair comparison with the physical pain and psychological pain, because usually when it's physical pain, by the time it's got so bad that someone wants to kill themselves, they can't physically do it. Where if someone has psychological pain, they still have the physical ability to jump off a bridge, to put a gun in their mouth, to take an overdose. There's not a physical barrier you have with physical pain.
Speaking as someone who's had reasonably severe bouts of depression, I can certainly say it's not necessarily when someone is at the peak level of the pain that they will try to commit suicide or succeed in committing suicide. It's when you're going either back down towards the low or coming away from it. And it's mainly, I would say, firstly, anything that's brought suicidal ideation for me is this sensation of going back to that place, that painful, horrible, dark place, or just coming out of it and thinking, I don't want to go back there again. And there's a point between being reasonably well and functional and a point between being absolutely in terrific pain that occurs, and that's when you and it occurs when you have the motivation to do it. And it's very difficult to. I mean, basically it's not when you're at the harshest of your pain. It's when you're coming through it, if you like.
Generally speaking, having also suffered from depression, when you're at your worst depression, you don't realize how bad you are because it lasts for a long time. You almost get used to it. When it starts to change, then you realize what was going on.
Thank you. That's exactly what we teach our students. You don't watch someone when they're at the worst. You watch them closely when they're beginning to get better, because that's when they've got the energy. The severely depressed person is as incapable often, if you talk about as going out and doing it, as severely physically ill. And actually, the worst physical pain is nerve pain. I don't know if you've heard of thalamic pain. It's not very common. It's made from sort of in there, that bit of the brain, thalamus, or trigeminal nerve pain, other kind of nerve pains that people have nerve blocks have really serious physical interventions for. Those pains are pretty horrific. They say it's like having a burning coal just held to you permanently. It's awful. And they aren't in any other way capacitated, it's purely a nerve pain. I think, just to show you that those are the references. As you can see, a lot of them are very recent. The oldest one I've used is the paper from the Lancet, which was 2003. The others are very, very new, so it is fairly new stuff.
If you give the references to Ash, I'll put them on the website, and they'll be on the website either tomorrow or the next day.
Okay, I'll leave them.
Just email me.
I'll leave them. Yeah. So, if anybody ever wanted to get in contact with me, it's really easy. Clio Bellenis nhs.net, or that's my personal email, aol.com. You don't even have to write it down, it's obvious. I'm not very good at being clever or subtle. Right.